Payment reform. Necessary but not sufficient condition for doing what we want to do. All right? It's important, but it doesn't work by itself. And we've learned that over and over and over again. You know, you've got to build what we're calling systemness. We've done this in 2 steps. Phase 1 was implementing a set of enhanced medical home pilots. I'm going to describe this in some details. In other words, we wanted to focus on the primary care practice as the cornerstone of any delivery system change. If you don't have a strong and effective care coordination and capabilities at the primary care level, nothing else is going to work, folks. And that's our belief, and we've been working for that. Phase 2 was to say, okay, we've done the work on the primary care side. How do we extend the reform to what Elliot Fisher calls the neighborhood of the medical home? The specialists that they work with, the community hospital where they practice, the other caregivers that are involved in the care of that population going forward. And that's where we start talking about accountable care organizations, or the word that we've been using is community health system, building on the IHI triple aim formulation, and we'll talk about that a little bit more. So those are the 2 steps. So, delivery system transformation, the mantra. Every system is perfectly designed to get the results that it gets. If it weren't, it wouldn't get them. All right? So if you want to change the results, you want to change the outcome, you got to change the design of the system. All right? So we've been working at that system redesign at 4 different levels of scale. And part of what I'm going to try to give you today is a framework, conceptual framework for that vision of payment reform that you're talking about. We've had to work concurrently at the first level, primary care practice, which we talked about. The second level is that community health system, sort of moving up a notch. The third level is state. In some places it'll be regional, but in our case it works at the state level because there's a very clear and much needed role of those state resources in providing some of this infrastructure and support, and then federal. Right? So those are the 4 geographic levels that we're working at. The other thing that we've worked on is you really have to start off in pilot communities. You cannot do this thing statewide in one fell swoop. That's our experience. It's a lot easier. We have competitions. Who's going to be the pilot? It helps galvanize getting the local resources interested, organized, whatnot. It's also less threatening to people if you do it as a pilot as opposed to doing it statewide. So systemness, systemness is not an actionable word by itself. So what does that mean from a functional standpoint? If an ACO is supposed to be more system-like, what does that mean? And we've identified 5 critical functions that you've got to have in order to function. First one is service integration across levels and setting of care. I deliberately do not use the word care, all right, because you're talking not just about health care, you're talking about a broader range of services for your patients that need to be coordinated across a number of settings in order to meet their needs. The second function is financial integration. If you're dealing with integrated budgets or different kinds of finances, it's cutting across individual providers, and you have to have a way of integrating the finances and understanding what's going on. Some of that is from the standpoint of financial reporting so that you know what is happening to the population that you're accountable for. You're talking about earlier in the Sutter presentation about this claims data, having access. That's part of financial integration. They pull it off their claim system. You can't get it from your payers here because they're too fragmented. How do you get the information that you need? Governance, this is absolutely critical. I think this is actually the pacing item. It's the most difficult thing to build. How do you create a credible governance structure which engages physicians, which physicians have confidence in, and they feel that they will be able to participate and their voice will be heard and be done effectively? It can be done. You see examples of it. You're going to hear some examples of it this afternoon. It is remarkably difficult, and it doesn't happen by signing contracts and signing papers and putting people in a room and saying, we now have an ACO. It really takes time for it to be credible and have confidence. Information, you have to have information tools. There's 2 things going on here. One is, in order for you to be proactive with your patients, in order to manage the care effectively, you need those information tools on a day-to-day basis to give you the information on your patients as they're coming in, as you're working with them. The second level is feedback and data for understanding the patterns of care that are going on, giving you the tools to understand, do population-based analysis, again, to do the kinds of work that you saw in Sutter. And finally, and again, this is one we came up with sort of towards the end, process improvement skills. Not everyone has the capability, inherently to do process improvement work. And we're talking both about clinical processes and administrative processes. We have trained every physician in our pilot communities in the Dartmouth Clinical Microsystems tools, the physicians and their staff, as part of the commitment to trying to give them more effective tools. So those are 5 generic functions. They can come from, the capability of doing this can actually, the help for doing this can actually come from any of the levels that we talked about on that previous. Some of this stuff happens in the practice. It has to happen in the practice. Some of it will happen more at that community level, shared by the practices in an area. Some of it really has to happen at the state level. If you're talking about a health information exchange and the ability to exchange information securely and appropriately across many settings and across communities, no single entity can do that. Really, that's a state function. If you're talking about getting all the commercial payers to the table to come up with a single system of payment for primary care as part of the medical homes, again, no practice, no individual system can do that. That was a state function to be able to pull that together, as you'll see. So some lessons and suggestions. We think that this community health system, the ACO level, is the focal point for real delivery system reform and for payment reform. That's where the real action is going to be. We don't know what structures work. We want to experiment with alternative structures. We have a FQHC, a federally qualified health center, that has merged with the critical access hospital. So you have a fully integrated health center model with the hospital as a subsidiary of the FQHC. That's a very interesting example. So I think that you're going to see a lot of experimentation. We have a statewide physician organization being created on with a regional basis, so dividing the state into 3 regions, so the state being too large and too ineffective. So we think that you will see, with a common denominators, you need 20 primary care physicians. There's lots of ways, lots of different combinations that you can put together 20 primary care physicians. Most small and medium-sized communities are going to need outside support for some of this infrastructure that a Geisinger or other people have run. I started off talking about that. We think that states fulfilling that role is a viable alternative. And as I said, this is not just Vermont. There are 9 other states that are engaged in this patient-centered medical home, state-sponsored patient-centered medical home work. There are 5 other states doing work on ACO support. So that's a model that's worth checking out. Don Berg says this is a period of incredible experimentation. All right, and I think that's the spirit, the attitude. We don't know what would work. And first of all, there's not going to be a cookie-cutter solution that works everywhere. Something that works very well in the northeastern kingdom of Vermont with FQHCs and rural healthcare is not going to work at Partners in Boston. Okay, you need different solutions. So you need different solutions, and you need experimentation on what works and what doesn't work. I'm interested in rapid cycle change, putting something in place, not talking it to death, but trying it, using some of the tools that you saw earlier, getting experience working those tools, and finding what structures actually support clinical engagement and driving the change. And we have a lot to learn about doing that.